purpose of this brief presentation is to address the technique for the evaluation of the amniotic fluid, the localization of the placenta, and the measurement of the cervix. The appearance of the amniotic fluid evolved during pregnancy. During the first part, the fluid is completely anechoic, and gradually during the second part of the pregnancy appears a fine echogenic content corresponding to debris to desquamation of the fetal and vernix. Measuring the amniotic fluid requires the assessment of all the pockets of the amniotic sac. We will perform sagittal section from the top to the bottom and then axial section from the right to the left. Two methods are available for the evaluation of the amniotic fluid. The first one is the index of Chamberlain, is a measurement of the deepest pool. We should be vertical to the abdomen of the mother. The norm is more than 2 centimeters and less than 8 centimeters before 20 weeks and less than 10 centimeters after 20 weeks. Second method, the amniotic fluid index, described by Fallon. It's the addition of the 4 quadrants of the fetus, and we will measure the vertical maximum pocket of these 4 volumes. The normal range is between 8 and 18. Less than 8 is oligohydramnios. From 18 to 25 is the excess of amniotic fluid, and more than 25 is what we call the hydramnios. The second point concerns the placenta. In the first trimester, the trophoblastic crown is uniform and hyperechogenic. It thickens over time, and from 14 weeks, we will look at fusion of the amniotic membrane with the chorion, and this extraembryonic coelom was disappear. During the second trimester, the placenta has a well-defined shape, with a thin stripe on the uterine side called the basal plate. This line is very important in the detection of placenta accreta. And on the amniotic side, we have an hyperechogenic plate, which name is the chorionic plate. At the evolution with the end of the pregnancy, the placenta will have an internal length around 20 centimeters and a thickness of about 3 centimeters. During the second trimester, venous sinuses begin to appear, which is easily visualized in the placenta tissue. These sinuses are only weakly filled on Doppler imaging. Then, later, they become more distinct because of the hyperechogenic appearance of the placenta. These venous sinuses remain easily visible along the pregnancy. The structure also evolves, and the classification based on normal criteria has been used. Also, it has lost its clinical relevance. There are 3 stages. Stage 1, where the placenta is homogeneous and relatively hyperechogenic. Stage 2 shows the appearance of an increased hyperechogenicity at the basal plate. And stage 3, this echogenicity become more pronounced and delimiting the cotyledon. But the clinical use of this classification is not sufficient to be relevant. The placental position is crucial to assess by ultrasound. It will be done by axial section from the top to the bottom. In this first example, the placenta is located under the probe and it's covers the anterior part of the uterus. In this second example, the placenta is in the uterine fundus, and in this last example, it covers the posterior part of the uterus. Regarding the low-lying placenta, we currently use an interesting classification related to the position of the placenta to the internal os. The first classification is placenta laterally inserted at 3 cm above the internal os. The second classification, the lower segment, is at the margin of the internal os. The third group is the placenta previa partial, where the placenta covers partially the internal os. And the last one is the complete placenta previa total, covering completely the internal os. Clinically, this third group is probably the most challenging because of frequent bleeding during the pregnancy. In case of suspicion of low inserted placenta after 20 weeks of gestation, it's essential to use vaginal ultrasound to specify the location of the lower edge of the placenta. In this first example, it's clear that the placenta is at distance from the internal os, whereas in the second case, the placenta covers completely the internal os with the vasa previa, and the ability to see these vessels is mandatory during the pregnancy to avoid bleeding before the birth. Here are other anomalies. The first one is the retroplacental hematoma, which is often not in ultrasound images. It's the clinical finding that provides the information. In this second example, the placenta shows calcification and it thickened, and it should consider infection. In the third case, we have a placenta accreta and previa. We can see no longer the line, the thin basal line separating the placental mass from the uterus with infiltration of the neighboring organs. In this case, we can see large vascular lacuna within the placenta. In the fourth example, the subchorial cyst gives generally no pathologic association. And finally, the chorial angioma, which is a true tumor inside the placenta or sometimes bulging into the amniotic cavity. This chorioangioma can threaten the pregnancy with massive venous flow inside the mass. The last point is the evaluation of the cervical length in the context of screening of preterm labor. The measurement of the cervical length should be done methodologically with careful transvaginal ultrasound, positioning the probe in the anterior cul-de-sac or the fornix. And you will observe the following images with 3 landmarks: the external orifice, the cervical canal, and the internal orifice with the amniotic cavity. The methodology is clear. There should be no excessive pressure in order to avoid lengthening of the cervix, nor insufficient pressure because we could have a bad visualization of the internal os. And finally, the measurement should be taken absolutely out of any contraction. Technically speaking, we will introduce the probe with delicacy into the vagina in the anterior fornix. Then we will perform 2 to 3 measurements and take the smallest one. And finally, we have to describe the internal os and the aspects of this orifice. Here are some examples of short cervixes. In the first one, you can see clearly that the cervix is shortened to less than 20 millimeters, significantly below the expected size of 25 millimeters, which is the threshold for the risk of premature labor. In the next example, we can see that the cervix is even shorter with the pouch protruding to the cervix. The functional cervix is only 5 millimeters. And we can sometimes evaluate the interloss by abdominal pressure. In this last example, we can see that the pouch is protruding between the two cervical parts, affluring the internal loss, the external loss. One last point on evaluating the cervical aspect is to search the sludge. Here we can see between the two parts of the cervical mass into the amniotic fluid. These are probably representing inflammatory structures with a very high risk of premature labor. To conclude, after this presentation, it seems straightforward to perform a qualitative assessment of the amniotic fluid, simple to position the placenta, and finally evaluate the cervical lens.